Hi everyone, it's Mr. Sinti, and today I'd like to talk to you a little bit about the beginning of the digestive system. And that's right, that's a discussion that's going to be all about the oral cavity. And so the oral cavity, i.e. the mouth, has a lot to do with the beginning of digestion, as you might imagine. As you can see in this picture, I decided to include a picture of someone eating a burger because it's one of my favorite foods to eat. But one of the things about digestion is that you have to physically break down food. That's digestion. So you physically break it down with teeth. So the food is smaller, but it also has an increased surface area as well, so that digestive enzymes will have their way at the food and help speed up the hydrolysis. In other words, the chemical breakdown of the food itself. And so chewing is going to be a part of this conversation. Some enzymes will come up in the conversation, and we'll talk a little bit about the anatomy of the mouth and the pharynx and the esophagus. Okay, so I hope you enjoy it, and let's begin. And so right out of the gate, let's talk about this. The oral cavity, which you can see here, is you get these salivary glands. And did you know you had 3 salivary glands? You have one right adjacent to your ear, one below your jaw, and one right below your tongue. And yeah, these are triggered not only by the presence of food, but sort of by the nervous system in the anticipation of food. Sometimes smell can trigger saliva. Sometimes the thought or the vision of food can do that. And if you're familiar with that famous study by the Russian psychologist Pavlov, where he was conditioning through associative learning, he was conditioning dogs to when they were sprayed with meat, or they had meat, and then he rang a bell, they began to associate something that's completely unrelated to food, like a bell ringing, and they began to salivate as a result of it. So it's pretty cool. And so what is saliva? So saliva, sometimes known as spit, but saliva is the more technical term. Well, it's kind of slippery, as most of us understand, and the slipperiness comes from the fact that there's a glycoprotein in it called mucin. And that sort of it protects the soft lining of the mouth, and it prevents the over abrasion of the inner cells that line the inside of the oral cavity, although there is a lot of abrasion. And so those cells, that mucous membrane of the mouth, those cells, epithelial cells, divide very frequently. And also the mucin helps the food to be able to swallow more easily, so it sort of lubricates the food. Also, you may not know this, but saliva contains some buffers, and a buffer is a chemical that acts as a sponge that sort of prevents major fluctuations in pH. And so what that does is it helps to neutralize the acid that's found in our mouth from eating, and so therefore it reduces the breakdown of enamel on our which is the outer coating of our teeth. So that helps to keep our teeth healthy. And then how about this? There's even some antibacterial agents in there. In other words, like chemicals that will destroy bacteria that help us to not get bacterial infections in our mouth, because food is laced with all kinds of bacteria. So the mouth, not saying that the mouth is free of bacteria, but it's helping a little bit. And so let's name those 3 salivary glands. So one's called the parotid salivary gland right there. And then this one's cool. This one's submandibular, meaning below the mandible right there. In other words, below the jawbone. And then sublingual refers to below the tongue. And again, those are ducts that lead the saliva to the oral cavity. Okay, and so what else is in that saliva other than the mucin and that I was talking about, and some water, obviously? Well, there's some enzymes, and the principal enzyme is an enzyme called salivary amylase. And you have to put salivary in front of the name amylase, because there's another amylase that's going to be produced a little bit later in the alimentary canal by another associative gland, or referred to as the pancreas. And so it's pancreatic amylase. And so the word amylase itself is interesting because it really is an enzyme that will speed up the breakdown of starch. Now, starch is a big, long polysaccharide of glucose. So it's a long chain of glucose, as you can see here. And so the enzyme speeds up water cleaving those glucoses. And so, as it turns out, the food doesn't stay in the mouth very long. And so, what salivary amylase ultimately does is it probably doesn't break it down to glucose. It breaks it into smaller starch molecules. But if it stays in the mouth food long enough, it might even break it down into the little two sugar molecule known as maltose. So it's a disaccharide. And so why isn't it called starchase? Because actually the other word for starch is amylose. So it's amylase. You always replace the substrate os with the suffix ase for an enzyme. And the truth is, most people don't discuss this, but there's a little bit of lingual lipase, which is a enzyme that helps to start to begin the breakdown of lipids as well in the mouth. But by vast majority, it's salivary amylase, and so you have a little bit of chemical carbohydrate breakdown happening in the mouth. Okay, so some salivary amylase is being produced by these glands right here, and again, the sublingual, the submandibular, and the parotid salivary gland. And so all of that's entering into the mouth. Pretty interesting. And so the first part of the alimentary canal is the mouth, and that's why we're talking about it. It receives the food, it physically breaks it down with teeth, and it mechanically and then chemically as well, as we were discussing. So let's look at that mechanical breakdown a little bit more. Let's talk about what's happening. And so in order for the teeth to get at the food, the tongue plays a really important role. The tongue, being that it's voluntarily controlled in skeletal muscle, is capable of moving the food around and tossing it from left to right. And then ultimately the food is sort of condensed into a little ball called a bolus. And then the tongue heaves it back and it's swallowed down into the throat, known as the pharynx. And so here's a picture of the bolus actually traveling down the esophagus right here. And so let's talk about this. So, the beginning of the oral cavity, the lips. Okay, so what's happening with these labia? Well, they're very sensitive to temperature, and so there's nerve receptors in the skin that are capable of determining temperature and judging the texture of food as well. And so that's kind of interesting. But then when the food actually hits the tongue could toss the food again, as I was mentioning, left and right, so that all the teeth can have an opportunity to grind up the food. But it's also lined with these little protrusions called papillae. And these papillae, inside of them, have these little tiny structures called taste buds, which receive the chemicals that are in food and that determine taste. So that's kind of interesting. And so the tongue itself is attached by this thin piece of tissue known as the frenulum. The frenulum is a cool structure because it's holding on below to the tongue right here. And as you can see, this person has a frenulum ring. I'm not sure about that, but maybe. Okay, and so if you look inside the mouth, if the doctor ever said, say, ah, and you look inside, what you got here is your hard palate. And the reason it's called hard palate is because it's very bony right here. And then the bone stops, and then you have your soft palate. And then that coalesces into this structure known as your uvula. Now, the uvula is important because during swallowing, it prevents food from going up into the nasal cavity. Okay. One of the things about the uvula is that sometimes it can be in an individual a source of trouble, because when a person's sleeping, sometimes the uvula will rattle when a person's expiring air. And so it can create a little bit of movement or vibration, which results in snoring. And so sometimes individuals will be snoring so profoundly that their partner suggests that they go in for a procedure that actually trims away some of the uvula. But it's not done lightly. Any surgery should not be attempted so cavalier, only in under extreme instances. And it's a kind of a slow recovery, and it's rather painful afterwards, and difficulty in swallowing. And then these structures right here are called the palentine tonsils, and there's two of them. This is your right, sort of anatomical right, and left palentine tonsils. We'll talk about those a little bit later. in the video. And so I thought I'd show you this. I was looking around for a photo of the uvula, and I found this. This is kind of unusual. This person has sort of a branched uvula right there. Thought you might find that interesting. So let's talk about these tonsils. And so when you look inside your mouth and you notice these palentine tonsils, and you're like, what are tonsils? Well, they're these spongy-like tissues, and they're really lymphatic tissue. Okay, so lymphatic tissue is a specialized tissue that houses quite a lot of lymphocytes and white blood cells, and it's a source of protection against bacteria, and it's a good place to put a lymphatic tissue right there in the mouth because there's a lot of bacteria that potentially are coming in. They produce antibodies because lymphocytes do that. Now, what can be a problem sometimes in individuals is that the palentine tonsils themselves can actually become chronically infected. Sometimes streptococcus bacteria and other bacterial infections can occur routinely. And the thing is, sometimes people need to see a physician regarding this, and maybe the option is to remove them. In other words, a tonsillectomy, the removal of the tonsils. And so, there's reasons for, reasons against. You could survive it because it's not the only place in your body that's producing antibodies, and so there's redundancy in the body. Obviously, it's not relying just on these tonsils to defend the entire body. And so that's their function right there. And then here's a nice shot of the uvula. And then here's a nice shot of where these palentine tonsils are, like right over here, especially when the tissue is pulled back. These folds, you can see them. And so, believe it or not, these can be removed. Okay, right there, tonsillectomy. And so, the palentine tonsils are not the only lymphatic tissue that's found in the oral cavity. There are some adenoids, which are technically, maybe not necessarily, a physician would probably debate this, found in the oral cavity, but really they're in the very back posterior part of the nasal cavity. And it's this again, lymphatic tissue that is defending the body from microorganisms coming in. It's principally from the nasal cavity. And so they're known as adenoids, and they can become infected as well, and these can be removed if they're chronically infected as well. They kind of sit right next to the eustachian tubes, which again is a tube that connects to the middle ear. And then how about this? We have a third set of lymphatic tissue on the very back of the tongue, and these are known as the lingual tonsils. So sometimes you can't see it because as the tongue sort of sits in the mouth, you'd have to really pull the tongue out to take a peek at this. So again, this is lymphatic tissue which defends the body from germs. And so this is a nice profile of the body, and you can see what's happening here in the nasal cavity. These are sinuses in the skull which reduce the weight of the skull. Here's your hard palate where the teeth are embedded. And then again, do you notice here where the bone stops? That's why this is a soft palate right there, which then coalesces into your uvula. Here's the tongue, rather muscular. The papillae are on the top right there. Okay. Here's the lips, and here's the teeth right over here. And then here's your palentine tonsils. Only one of them is being shown here. Here's your lingual tonsil right here. And then again, the pharyngeal tonsils are also known as your adenoids, and those are sitting right up there. Okay, so your three sets of tonsils, if you will. And then below, we're going to get into this conversation now. We're going to get into this back area right here, which is the back of the throat, known as the pharynx. And then this little structure called the epiglottis, when food is swallowed, it helps to then close so that food travels where it appropriately is supposed to go, which is down into your esophagus. You don't want the food, or bolus, to go down into your trachea through that opening called the glottis, even though it's not labeled. That's why this is called the epiglottis, this little tissue here, because it's above the glottis. And then this is the opening of the trachea. Okay? And as you can see, the trachea is kind of a larger tube, and it's opened by these C-shaped rings of hyaline cartilage. And then the esophagus is kind of thin muscular tube, which then can elongate and widen when the bolus goes down, sort of like tights. If you were to stick a tennis ball in a pair of tights, it would elongate and stretch like that. Okay, and so let's get into a conversation of teeth, because they're really important in terms of mechanically breaking down food. Did you know that when you were a youngster that you had 20 primary teeth, or sometimes they're called baby teeth? Sometimes they're even called deciduous teeth. I find that kind of humorous because, like a deciduous tree, the teeth fall out. And then they're replaced by the 32 permanent teeth, or adult teeth. Now, not all of you may have all 32 of the teeth, and it will vary from individual to individual. But what I want to get into is a conversation is that the teeth themselves, the shape of the teeth, are beautifully designed to carry out the particular function. And so it's a great example of structure related to function. So the teeth in the front, so I'm going to just label them here. This one, this one, this one, and this one. And again, it's the upper teeth are a mirror of the lower ones. So when I say these ones, I also mean 1, 2, 3, 4. These are known as incisors. So like a scissors, they're capable of cutting or biting. And then once you bite into something, maybe instinctively you'd want to sort of heave it over and tear. And so the teeth that are capable of tearing are, let's see, 1, 2, 3, 4, and then this one, 1, 2, 3, 4, this one, and this one. These are known as cuspids, or canines, because they're particularly pointed and cone-shaped in wolves and dogs, that sort of thing. And so these cuspids are capable of tearing the food. And then right adjacent to the cuspids, these two teeth, this one and this one, are known as bicuspids. And let me switch to a different picture so that you can get a better look at this. So here are your incisors right there. Here is the cuspids right there and there. And then these two teeth right here are your bicuspids. They're sort of like transitional. They're kind of like molars, which are flat. These are the 3 molars. And they kind of come in that order too, like 1 molar, 2 molar, and then the third one is the last one to come in, sometimes known as the wisdom tooth, because it comes in around in high school. And so maybe it's a signification that you're becoming wise. And so again, this side and this side are the same. So you have your incisors, your cuspid, your 2 bicuspids, and your 3 molars. And so you get a total of 16 and 16 and 32. And then up here, the gums are sometimes known as gingiva. And then again, you have this little frenulum, but this frenulum is not the tongue frenulum, which is the lingual. This one up here is connected to the upper lip, if you're familiar with that. And this is known as the superior, meaning it's on the top, labial frenulum. And then down here is the inferior one. And the vestibule is that little space in between the lips and the teeth. So kind of cool. Then you can see the uvula here, and then you can see the palentine tonsils over there. So here are your baby teeth. Again, only 20 of them. Kind of cute. And again, when they fall out, don't forget to put that under your pillow for the tooth fairy. And then over here, we're looking at our incisors. These are the central ones. These are the lateral ones to the side, your canine or your cuspid, and then bicuspids or premolars, and then your 3 molars right over there. Okay, so the pharynx, as I referred to before, is the back of your throat. And again, the swallowing process is begun when the tongue hoists the food back, and then the epiglottis closes over the glottis to prevent food from going down your trachea, so that the food does go back into the esophagus. Oh, I'm sorry, pointing to epiglottis, esophagus, which is right over here. Okay, and so here's your esophagus right there. So this ensures that epiglottis closing ensures the food that doesn't go down in your trachea. Now, if it does, if food does get blocked in here, one way to continue breathing is to actually perform an incision right in the person's throat and like find the space in between the cartilage and actually penetrate that, and maybe put something hollow there like a pen to allow breathing to still take place. Now that's kind of a severe situation. Sometimes the Heimlich maneuver is essential, where you put pressure on a person in the abdominal cavity, and it forces out the bolus, and it goes down the esophagus or out the oral cavity, depending. And then here's sort of a diagram of swallowing, where the bolus is then again filled with the mucin, is moved down, and then it travels through. Notice here the epiglottis is then closing, and then the food is moved down through wave-like contractions known as peristalsis. Okay, and so you could see here the food entering then into the stomach, and the sphincter closing off right there, and then here's the peristaltic wave-like contractions. And so we have a pretty good understanding of swallowing because we have little tiny cameras that can actually go down, called endoscope, and you can actually look inside the esophagus, and you can go all the way down into the stomach if you'd like. And so we can actually have video of that. And we also have X-ray, believe it or not, of inside looking at the food being swallowed. And so down below, these are involuntary contractions of smooth muscle that will take over and move the food all the way down into the stomach. The thing is, you want the food to stay in the stomach because the stomach fluid will then mix with the bolus, and the stomach secretions, which I'll talk about in a separate video, are quite acidic. And so you don't want that acid chyme, as it's referred to regurgitate back up into the esophagus. So you have this sphincter of muscles called the cardiac sphincter, which will prevent that. And if that doesn't work properly, you'll get a little burning sensation known as heartburn. And again, down here, the pyloric sphincter will keep the food inside the stomach so that it's able to be broken down. Now, I mentioned that there are some X-rays. I thought I'd show you some. Take a look at this. This is kind of interesting here. Here's a person who's actually like swallowing. Look at this. And so they're chewing. And do you see here? Now notice here the epiglottis where I'm pointing right there. I'll make it a little bit larger. You can see here's a frontal view of that. It's a person swallowing. You can actually see the bolus traveling down the esophagus. And then all the way down, there it is, traveling down the esophagus right there. And then you can see this movement is the heart. And so we're going to go all the way down into the stomach. Pretty interesting, I think. Take a look at this one. That's really good too. Enlarge it. Here's again a person chewing the food, and then you can see the bolus being pushed back down, and you can see the epiglottis working really well, blocking the trachea so that there's no food getting in there. And so take a look at this.
Video
this is
off. Good. Recording.
Let's see. Let's listen to this.
Swallowing occurs in 3 stages. The first is a voluntary phase called the buccal or oral transit phase. Here the tongue moves upwards and backwards against the hard and soft palates to push the bolus into the oropharynx. Next is the pharyngeal stage, in which involuntary movements push the bolus through the pharynx and into the esophagus. Movement of the bolus stimulates receptors in the oropharynx, which send impulses to the deglutition center in the medulla oblongata and the lower pons of the brainstem. The brain signals the soft palate and uvula to close off the nasopharynx, and the epiglottis to seal off the larynx. This prevents the bolus from entering the respiratory tract. The upper esophageal sphincter relaxes to allow the bolus to move into the esophagus, and contracts to reduce backflow into the pharynx. In the final esophageal stage, the bolus is pushed onward by peristalsis, a progression of involuntary wave-like contractions of the circular and longitudinal smooth muscles of the esophagus.
And we saw that
As
in
the
the
bolus
X-ray.
approaches the end of the esophagus, the lower esophageal sphincter relaxes and the bolus moves into the stomach. So, in summary, food moves from the mouth, through the oropharynx and esophagus, and then into the stomach.
Pretty interesting. Okay, so I hope you enjoyed this discussion of the oral cavity, and thanks for watching.